This is a 68-year-old male patient. He had a history initially of fevers, night sweat, and weight loss. He had abnormal LDH and diffuse lymphadenopathy on both sides of the diaphragm, but no bone marrow involvement, not CNS involvement. This was on the biopsy, typical diffuse large B-cell lymphoma, which was CD10 negative but BCL6 positive, and who was classified as non-GCB, but with the overexpression of MYC and BCL2 protein, but without any translocation. So the patient received rituximab CHOP, relapsed 1.4 years later, received DHAP and ASCT, but unfortunately relapsed again and just had received CAR T therapy.
Okay, thank you. I will thank you for the opportunity to discuss this case as well from a European perspective. These are my disclosures, by the way. If you look at the results of CAR T-cell treatment in general in diffuse large B-cell lymphoma, and you look at the pivotal phase 2 trials, you can see that for the patient in this case, for the different constructs, the overall response rates vary between 50 and 80%, and the best CR rates vary from like 40 to 60%. And the median duration of the response can be pretty long, but all in all, only approximately 40% of the patients have long-term benefit. So of every 10 patients treated with CAR T-cells, 4 patients will have a long-lasting response. And the relapses following CAR T-cell therapy can be either antigen positive or antigen negative. So if you look in general at the mechanisms of resistance, there are several mechanisms. It can be lack of persistence. The CAR T-cells don't expand very well, or they are rejected soon after infusion. Another possibility is the loss of the target antigen, or there can be dysfunction of the T-cells, which can be intrinsic due to the fact that they're probably overactivated. They can become exhausted pretty rapidly, or it can be extrinsic factors from the microenvironment, which can be sort of hostile. And recently, interestingly, also some defects have been seen in the death receptor signaling pathways. Another possibility is the upregulation of immune checkpoints such as PD-L1. So definitely, I think if a patient relapses after CD19 CAR T-cell therapy, we would always try to confirm this relapse by biopsy. And this is important for several reasons. We would like to exclude pseudoprogression. We have seen in some cases a sarcoid-like reaction, which could also disappear spontaneously. As Kieran said, we would like to see whether the lymphoma is still CD19 and or CD20 positive. We would look for biomarkers such as checkpoint upregulation and cell of origin, if not already known before the treatments, that would be interesting, and whether or not there are any targetable mutations. And then, of course, it's very important, depending on the performance state of the patient, to discuss the preference for treatment. If the disease is very rapidly progressive and a patient is in a very poor condition, there's also the option of best supportive care. But if there are grounds for looking for a new therapy, you could also argue it might be important to see whether there are still CAR T cells around. So you could check the peripheral blood for persistence of the CARs. And if there are still CARs around, you could argue you could try to avoid T-cell toxic therapy. It might, if it's localized disease, do, for example, radiation therapy or a clinical trial, for example, with a bispecific antibody. If there are no more CAR T cells, you would be less worried about eliminating them, and you could also give immunochemotherapy. What about a second infusion of CAR T cells? So in the ZUMA-1 trial, there were some patients who had a second infusion, and this was recently discussed also by Fred Locke, who described 14 patients with a second infusion, and they were eligible for the second infusion if they had a prior remission and no loss of CD19, and this could be done with either a second bag, which was already available, or with a second manufacturing from the cryopreserved PBMC, the apheresis material, or in one case from a new apheresis. And in this case series, the median interval to retreatment was 9 months, and the overall response rate was reasonable, 57%. The median duration of the response after retreatment was 9 months, and only 2 of the 14 patients were still in remission at 11 and 18 months. There was a comparable rate of CRS and fewer grade 3 neurotox, but the peak CAR T-cell expansion was actually lower upon the retreatment versus the first treatment. So conclusion from that presentation was that retreatment is feasible, but the responses are often not durable. And you might consider using that as a bridge, for example, to allogeneic transplant if a second remission is found. And another problem is that this is currently not on the registration label and also not reimbursed. So what about new CAR T-cell constructs, for example, using combined or multiple targets such as CD19 and CD22, or new constructs, for example, TRUCs, which also express and release cytokines, or a combination with other agents such as ibrutinib or immune checkpoint inhibitors. A lot of these approaches are currently being employed in clinical trials. So Kieran has already discussed with you a lot of options, so I won't go through those options again. I think in the meantime, we know a lot about how lymphomas develop and what are the mutations, but it's not a very simple story. It's a complicated story where there are so many significantly mutated genes that have been identified, but some of them are actually targetable. But the responses with these targeted agents so far have been disappointing, I would say, in terms of duration of response. So what's the situation with access to novel drugs in Europe or in the Netherlands in particular? Often, I must say, EMA approval comes later than FDA approval, and subsequently there's a complicated system of reimbursement and access, which differs per country. So for some countries like Germany, there is direct access after registration. And in other countries such as France, there can be an ATU, for example, a temporary access program. Whereas in the Netherlands, if there's a new expensive drug, this will be evaluated by the Healthcare Institute. They will do a health technology assessment. They will look at the therapeutic value, but they will also do a cost effectiveness or a cost utility analysis from a societal perspective, and that can be already challenging if there is no standard of care arm, which for most of these newer agents, there is no standard of care. And then a budget impact analysis is done. And then the new treatment, in most cases, is placed in a sort of a lock, waiting for price negotiations between the Minister of Health and the company, and these price negotiations are secret. And that can take a long time. For example, for CAR T cells, before they were available commercially in the Netherlands, that took about a year. So for our patient who has a relapse after CAR T cell treatment, I would say a clinical trial would be the best option. And in our network, we would have clinical trials open, for example, with epcoritamab, which is a CD3, CD20 bispecific antibody, which shows really interesting results already in the dose escalation phase, and with relatively mild treatment emergent adverse events. Another trial which is open is the trial with blinatumomab in combination with pembrolizumab. And we would have a trial open with a novel CDK9 inhibitor, which is very potent and highly selective and suppresses MCL1 and induces apoptosis. So that would be the options for our patients, in terms of a clinical trial. So with that, I would like to end and give back the floor to Gilles.